Today I'll discuss the case of a middle-aged man who presented with shoulder pain. I saw him for 8 visits over a total of about 10 weeks, and it's a long case. There's a lot of details that I want to share which make the case interesting and informative, and it's one of those cases as a clinician you kind of get excited about because at least I recognize that maybe 5-10 years ago I would have treated this person very differently, and I think my care now is so much more effective as a result of getting better at what I do for a living. So this man presented with left shoulder pain that was kind of global to the shoulder, and there are many parts of his history that were very important. One was that he had had pain on the right shoulder the year prior, and when I asked him more specifically about that shoulder, he said it was just pain, it wasn't lack of mobility. So that's an important key point. Secondly, the left shoulder pain that he presented with had started almost a year ago, but was getting worse as of the last half of a year. He had already tried chiropractic treatment for roughly 6 or 8 visits with no change. I asked what the diagnosis was from that clinician. He said it was tendinitis. And then a week prior to seeing me, he had seen an orthopedic MD who had diagnosed him with left frozen shoulder. In terms of why the pain started, there was no apparent reason, which is what many of my patients say, if not most of my patients. And I asked about a spinal history. So has your neck ever been stiff or painful? He said yes, intermittently it had mildly affected him, but nothing that he had sought care for. So when I asked about what made the pain worse, the pain was intermittent. For the left shoulder, he said reaching across his body, reaching up his back, sleeping on both sides, so left side and right side, taking on and off his belt, putting on clothing, taking off clothing, and raising his arm. So he was better. He could avoid pain by avoiding doing those things with his arm, but he wanted to be a normal person, of course. Sleeping, reaching, doing his workouts all involved shoulder motions that at that time were painful. He had been diagnosed with pre-diabetes and was taking steps to change his diet and do intermittent fasting. We know that frozen shoulder or adhesive capsulitis, for that one risk factor is insulin resistance, diabetes, metabolic syndrome. So that piece of information is also germane to his presentation of left shoulder pain. He'd had an x-ray of his shoulder, which was negative, and that was the gist of it. The key point, though, I really was interested about was that it's been there for a year. There's no trauma, and the other shoulder hurt the year prior without loss of mobility. But this one, not only was it painful in those motions I mentioned, but he noticed a significant loss of motion. So coming out of the verbal history, it doesn't sound like a tendinitis. It sounds like, to me, because of the right shoulder pain the year prior, without loss of mobility, it sounds like there's a spinal component. It could also be frozen shoulder. I didn't know how stiff it was. He did say there was stiffness and loss of mobility, but I didn't note this on my paper, but I do remember that I did ask him, did it follow this pattern? Because frozen shoulder has a pattern of freezing, being frozen, and thawing, roughly 3 stages, where in the first stage it's just getting more and more painful, more and more stiff, and then it kind of plateaus in how stiff it is, how rigid and loss of mobility, how much loss of motion it has, and the pain kind of plateaus. And then after several more months, it can start to thaw. So the mobility will start to increase very gradually. And I remember asking him if it seemed to have followed that pattern, and he said no. It wasn't ever several months of increasing intense pain. He just kind of had more of a steady state of pain for the past year, primarily with movement. So out of that verbal history, I'm thinking more likely spinal. especially with a history of neck stuff, although most people will say they've had a stiff neck or a painful neck at some point in their lives. But frozen shoulder or shoulder joint derangement is also on my list of things that I want to assess for when we get further into the exam with the physical exam and then any testing we want to do. So when it came to the physical exam for his left shoulder, minimal loss of flexion with end range pain, moderate loss of extension, horizontal adduction going across the body, minimal loss with pain, abduction, minimal loss with end range pain, internal rotation up the back, moderate loss with pain, and external rotation. When I did a quick look of it in standing, it made me want to look at it in supine because it seemed so restricted. So I wrote down major loss of external rotation with pain. And when I put him in supine and took his shoulder into external rotation, what I'm expecting is about 90 degrees for patients, and his was maybe 20 or 30 degrees. So very significant loss of external rotation, and his unaffected arm, his right shoulder, moved well. And in supine, his right shoulder had about 110, 120 degrees of external rotation. So significantly more than average, and shows the barometer that we need to get to for the affected shoulder. It doesn't need to get to 90 degrees of external rotation. It needs to get to 120 or whatever the other one has. That was his movement loss in the shoulder. Shoulder strength, shoulder muscle testing could produce some pain with certain movements, but it was 5 out of 5. Now I looked at the thumb and the fingers and the elbow. The wrist was 5 out of 5. Thumb extension was 4 out of 5 on the left and 5 out of 5 on the right. So that starts to make me think more there is a neck problem. Whether it's creating all his shoulder pain and immobility, we don't know, but there's probably or possibly something in the neck if thumb extension is weaker on that one side. And then neck mobility was another big part of the physical exam, and I'll go through all 8 of these. Protrusion of the neck was full, producing the left shoulder. Flexion was full, producing left shoulder pain. Extension was minimal loss with deviation mildly to the right, and it produced shoulder pain. Retraction was full, produced shoulder pain. Right rotation and left rotation were symmetrically with a minimal loss, and right side bend and left side bend were symmetrical with a minimal loss. So things in the sagittal plane produced his concomitant left shoulder pain, his familiar left shoulder pain. And the deviation and extension, which is not that uncommon if you look for it, the deviation is almost always away from the side of pain. So he presented with the deviation and extension. So after that part of the physical exam, I'm thinking there's definitely something in the spine contributing to this shoulder problem, but we haven't done the testing yet. So I didn't do nerve tension, probably because he couldn't get any external rotation of his arm, but he did not complain of any symptoms below the shoulder. So I chose to do the test of repeated movement testing to help me get a better idea of the diagnosis. Was this frozen shoulder? Was this a mechanical problem in the neck? Was this a mechanical problem in the shoulder joint? Was this a tendon problem? We're not thinking it's tendon based on the physical exam and the history, but that's what I'm thinking about when I choose to do repeated movement testing. I chose not to do any orthopedic special tests of the shoulder or the neck, for example. I think the repeated movement testing will give me the best information. So I chose to start with repeated retraction extension of the neck and seated. It did produce that deviation each time to the right. It produced his shoulder pain each time, but he wasn't worse afterwards. So it, created that pain for a second when he went back and then didn't remain worse. After we did 3 sets of 10, there was an increase in the functional internal rotation of the shoulder, abduction, flexion, spine rotation was improved left and right of the neck. There was no effect on the shoulder external rotation mobility. I saw enough evidence of change that I wanted him to go home with retraction extension over a chair. And in his history, we did touch on what his mechanics were for most of the day, and he said that he does sit at a computer for work a lot. And yes, he likes to work out, but he knows that he's kind of probably in a flexed or slouched posture a lot of the day. So we did talk about posture. And at the end of my evaluation sheet, I wrote down as provisional diagnosis, spinal joint derangement plus possibly frozen shoulder, but with question marks, because I don't know what's going to happen. The testing is going to be performed at home. That's the testing nature. That's the nature of repeated movement testing, is you have to do it repeatedly. While 30 may seem like a lot, 30 joint movements in the presentation or the paradigm of daily movements is not that much. We move our neck thousands of times per day. So we need to get hundreds of movements to really understand how the musculoskeletal system is going to respond. So posture and retraction extension times 10, roughly every 2 hours, was his home program, which I'm not calling treatment necessarily. It could be, but it really is testing. Like someone goes to get an x-ray or goes to get an MRI or does any other functional testing outside the office, I'm sending him to his house and to his office to do his functional testing, his repeated movement testing. He came back, visit 2. He said he had adjusted his computer and his chair for the postural changes that we were aiming for. He adjusted his car seat. He did his home program 3 to 4 times a day, so not the dosage that I had prescribed, but he did 10 to 15 reps each time. He noticed he was slightly better. He had more internal rotation up his back, less discomfort with lifting, and decreased pain with reaching across his body. So he also noticed that he could still produce that pain when he did the exercise. So it would still, when he did retraction extension, he would still feel some left shoulder stuff very quickly. Moving on to the physical exam of our second visit, active range of motion and passive range of motion in the shoulder were a little bit better. And then I'll speak more generally. In the neck, or I'll speak generally about the shoulder. In the neck, let's be specific. Protrusion, no loss, no shoulder pain. Flexion, no loss, no shoulder pain. And then retraction, no loss, still produced the shoulder pain. Extension, more range of motion, still a very mild deviation, and it still produces shoulder pain. And then the side motion, side bend and rotation were improved. So I asked him to show me how he did the home program. His performance was good. We did several sets and I didn't see a big change in his baselines when we retested. So I added overpressure by having him apply pressure to his chin when he's back over the chair, getting to full end range extension. We did 20 of those. It would still produce his shoulder very temporarily, not remaining worse after the exercise was stopped. And I could see decreased deviation with repetition and slightly better shoulder mobility. So we added that overpressure to his home program, and that was the only change to his home program, but I was encouraging him to get to the 6 sets throughout the day as a minimum. On visit number 3, he said he was doing it 6 to 8 times a day, slightly better still noticing that there was a decent amount of pain when sleeping on that side. So looking at the neck, there was no more deviation and extension, so that was a really positive change. Right side bending had no loss. Left side bending still had a very min to min loss, and right rotation and left rotation were still kind of symmetrical. So now we're seeing an asymmetry in the side bending away from the side of pain and toward the side of pain in terms of his, and those shoulder motions, those neck motions did not create shoulder pain. However, when he went to the left, for the first time, he remarked with left side bending that it feels like there's a ball stuck in his neck. It just felt like an obstruction. He didn't use the word obstruction, but that's the word I use. I think of mobility and restriction and obstruction. Is it restricted because tissue on the opposite side of the movement is limiting it? Or is it not moving because of obstruction? And sometimes people perceive that obstruction, like it just feels locked, it feels stuck. Other times they don't. But when I try to think of what's causing immobility, the 2 big ones that come to the front of my mind are restriction of tissue and obstruction of joint mechanics. You could also have obstruction if there's a tumor in the way or a fracture of a bone is in the way. But mostly in an orthopedic outpatient setting, we're not seeing those things. We're seeing obstruction, what I perceive as caused by joint mechanics, whether it's joint mechanics in that joint or in the related joint in the spine if it's an extremity problem, or more proximal joint in the extremity for a more distal extremity joint obstruction. So looking at his shoulder baselines, flexion was a little bit better, abduction a little bit better, functional internal rotation a little bit better, slightly better external rotation, but that one's really not moving like the other ones in terms of improvement of mobility. So because his extension had normalized in his neck, and because he now felt that obstruction going left, I decided to look at going left. I thought we'd gotten all we could out of the sagittal plane up until this point. Now, at this juncture, clinicians could choose different things, different paths, but I was thinking we needed to go left. The symptoms are only on his left these days, and that obstruction made me think that we needed to clear something on the left side before we may proceed back to sagittal plane. Sometimes we have that sequence of events where we get all we can out of the sagittal plane. We need to go lateral, rotation, side bend, etc., side glide in the lumbar spine, and then that clears that lateral side of the joint, and we can go back to the sagittal plane. Usually the motion that we were doing before, which for him was retraction extension. So we looked at retraction, slight retraction with left side bend. We did 3 sets of 10, and then I did 3 sets of 5 where I applied some overpressure with my thumb and my hand pushing his neck into left side bend. And afterwards, he noticed that shoulder mobility, we got a little bit more flexion, abduction, and external rotation, and he felt looser going into the left side bend, so not as much of an obstruction with that ball-like feeling on that left side of his neck. So we changed the home program to left side bending with overpressure. So for left side bending with overpressure, the patient can slightly retract and use that hand. If this hand is really irritated or arm from nerve symptoms or other symptoms, we can always do slight retraction, side bend, and pushing with the opposite hand. I don't really have much of a preference if I can observe that the patient's getting the right direction and magnitude of force. So left side bending was his homework. If he could get his girlfriend to do some overpressure with her thumb and her hand, then I said, feel free to try that. Some extra pressure might be helpful. And he took that on board, and he was able to do that. On visit 4, he said about 1 time a day he had his girlfriend mobilize his neck. He noticed some neck pain when he did the exercise only, but it didn't remain. His neck motion, he noticed, can still produce a little bit of that left shoulder pain when he reclines or retracts. He noted that he did the homework at least 6 times per day, and sleeping on the left side was now better, and reaching across his body was better as well. As I asked a lot of times patients to give me a number, so I asked him for this example, like, well, reaching up your back, you're telling me that it's better, how much better? And he said 80%. So we're on the right track with getting his movement improved to a pretty significant extent. On that 4th visit, extension of the neck was still no loss, but could produce that shoulder. Left side bending, no more obstruction, nil loss, but could produce that shoulder. And rotation right and left, no loss, looking good. So now when we think about the shoulder, still a very minimal loss of flexion. It has improved, but there's still a minimal loss of flexion with pain at end range. Horizontal adduction, very minimal loss. Abduction, very minimal loss. Internal rotation up the back, very minimal loss. All of those with pain at the end range. And external rotation was now about 80 degrees. So to me, this is something I would not have guessed would be possible. I would not have guessed that just moving the neck, remember, all we've done is retraction extension and left side bend with some overpressure, improved his external rotation of his shoulder from about 20-30 degrees to, I wrote down, we're at 80 degrees now. And I wrote down here that the other side, the unaffected side, was 125 degrees. So that's a huge change. When I see 20 degrees of external rotation or 30 degrees of external rotation, it would have been really hard for me to imagine that just moving the neck would get that up to 80 degrees, but it did. There was no other homework. I'm not hiding the fact that I gave him this exercise and also told him to stretch his shoulder, right? There was nothing. He's just moving his neck, preferably 6 times a day, and attending to his posture to prevent a lot of flexion force through his neck at this time. So I decided, or here's what we did for the repeated movement testing on that visit. We did the left side bending with overpressure, and it didn't have an effect on his baseline. So we're not going to stick with that because it's proving that it's no longer fruitful. It's not going to give us more and more range of motion or more and more improvements in pain. So I looked at returning to what we did in the past. So retraction, extension, overpressure over the chair. Like I said, many times in the spine, if we plateau with sagittal, we go to the lateral component, we need to clear that, then the remainder of it can be fixed by going back to the sagittal plane. But this is all about cause and effect. We have to do the test and prove to ourselves that it's worth continuing at home. It's not just try it. We have to see some efficacy in the clinic before I'm going to ask a patient to give me 10 minutes of his life doing an exercise. So prone retraction extension is where I went next. It's often the place I go next if seated is not fruitful, if I want to stay in the sagittal plane. We could go to supine, but prone is where I find a lot of help. So I went to prone retraction extension, sustained. I did 2 for 30 seconds and no effect. But as I mentioned in a prior video, because I was so convinced there was something more there, I didn't abandon it. So the history, the physical exam, everything I'd seen in these visits up till now, 4 or 5 visits, I really wanted to do more. I was convinced there was something left in the neck. Again, going from 20-ish degrees to 80-ish degrees of external rotation of the shoulder just by moving the neck. We know there's a neck problem and it's significant, so I was thinking there was still something more in the neck to fix. So I had him do it for a minute twice, and it didn't hurt when he did it, and afterwards better shoulder movements and better left side bend of his neck. So I had him do that for his homework, switching back to retraction extension, so sagittal plane movements of the neck repeatedly throughout the day, but instead of doing repetitions, I had him doing it sustained on his stomach, propping up in that sustained position 1 minute or more at least 6 times per day. On visit 5, he said he was only doing about 3 times a day because of life got in the way, but he was noticing he was much better. So his physical exam, flexion, very minimal loss in the shoulder, abduction, very minimal loss, functional internal rotation, very minimal loss. I wrote down 1.5 inch difference between the right and the left, and external rotation still at about 80 degrees in supine. Neck motions, though, I wrote down all 8 motions looked full. Now, that doesn't 100% mean they are full, right? Because it can look full, but you could be missing a millimeter in C6, C7, and I can't see that. Testing is what bears that out. But I decided to look a little bit at some other things because he was doing it 3 times a day and he was much better. So I repeated that exercise, right? We did 2 for a minute to see if it was worth continuing, and there was no effect on shoulder range of motion, so I didn't belabor doing more of that. So I looked, this is, again, my clinical judgment. Clinicians will do this differently, but I wanted to quickly see if there's anything in the upper thoracic. So I had him in prone and I mobilized his upper thoracic extension, or the upper thoracic spine in extension. So a PA mobilization. It produced some shoulder pain when I did it, but it had no effect on his baselines afterwards. I decided to quickly just make sure I wasn't missing anything with supine neck retraction extension off the plinth with little traction. We did that, it had no effect. And then I was like, well, maybe I'm missing the retraction extension of his neck by not getting him high enough. So I had him do it one more time up on some folded towels under his elbows to get him even into more extension, and it had no effect. So then I was thinking, all right, let's move on to the shoulder, and maybe there's a mechanical problem in the shoulder joint itself. It's either that or it kind of is a little bit restricted in motion, similar to frozen shoulder, but not, right? Because the loss of range of motion at this point, in general of his shoulder at this point, he has, 85% of his motion of the other side for all of the motions combined. So it's not presenting like a frozen shoulder, but it is presenting like I've lost a little bit of motion in many planes. So I looked at functional internal rotation of the shoulder repeatedly to see if there was a joint mechanical problem where one movement or 2 will unlock all the other motions. We did 20 of them with overpressure up the back, and it produced some shoulder pain when he did it, and afterwards it looked like abduction and external rotation were improved with decreased pain. So now his homework was continue with the neck one on his stomach when he could. up to 6 times a day, hopefully, because it was so powerful, but try to get the functional internal rotation up of the shoulder, up the back, either pushing, I forget if I had him push under his elbow or hold or wrap a strap around him and pull that up, but try to get 10 of those 8 times a day. So visit number 6, when I quantified how much improvement we've made up until visit 6, he said 85% better overall. He was consistent with his home program since the last visit till now. He did add the strap to doing the functional internal rotation of the shoulder up the back. Over the week, he said that it was less and less painful to do that exercise. So no big changes in his shoulder range of motion, still a little bit of loss. External rotation, I put, we gained a few degrees, but it wasn't off the charts. So we did that exercise more in the office as is normal to see if it's still fruitful. I added some clinician overpressure, pushing his shoulder really high into functional internal rotation. We looked at repeated extension of the shoulder with some overpressure, putting his hand on the table and squatting down. And I also looked at functional internal rotation on his side, so what's commonly called the sleeper stretch. So I looked at these things and then measured the baselines after we did each one. So we did 10, 20, 30 of each one, and I would see, is this really changing your baselines? And I didn't see much change. So now I'm starting to think, all right, I don't think this is a shoulder mechanical problem, because we've looked at 3 or 4 different loads of the shoulder that I would have expected to change for someone with this presentation. And it didn't change. It's not like we did internal rotation on his side, and then he gets up and his flexion is markedly better, or his external rotation is markedly better. I'm looking for rapid changes when it comes to a mechanical problem, right? Changes you can see in front of you that warrant doing it more and really investigating over 24 or 48 hours or more what the effect is. So I decided to keep him on the prone retraction extension of his neck, decrease frequency, just because of, again, the potency of that exercise for him. And shoulder extension, I had him add some shoulder extension into his life to kind of loosen that one up. On the off chance that all of his motions got better with that, that's good. But what I was really thinking would happen is he'll get a little bit more shoulder extension. So the functional internal rotation he did over that week or so gave him more functional internal rotation, but it didn't seem to improve the others. That's kind of what I thought might happen with extension, which is fine. We want to improve his extension, but it would present like a mechanical problem if the one motion unlocked more than one motion. So he came back visit 7, somewhat looser. He'd been consistent with his home program, similar response. Everything's a little bit better. I looked at horizontal adduction of the shoulder and horizontal abduction of the shoulder, just to see if, again, I'm missing a mechanical problem, because you don't want to miss a mechanical problem. Those are the ones that are easy to fix we're talking in days. Tissue restriction or tight tissue will take longer, weeks to months to remodel in some cases. So I decided, after looking at that and not seeing a major change, that I don't think there's a mechanical problem in the shoulder. I think it's restriction. I would not use the word frozen shoulder when it's such a minimal loss, but minimal loss in extension, abduction, external rotation, flexion and internal rotation were pretty good at this point. So I had him just keep his neck thing up 2 to 3 times a day if he could, to make sure we're going towards a maintenance program of maybe once a day or however much he needs, but weaning off of the neck exercise. And then the shoulder, I said 2 to 3 times a day. I want you to take it all the way to end range extension, external rotation, abduction, and horizontal adduction. So 10 to 20 times in each direction. Those are the 4 ones that were really still lacking. So extension, ER, abduction, and horizontal adduction. And this is just a stretch, right? We are trying to stretch that tissue, that capsule, the tendons, the muscles, whatever it may be that's restricting his mobility. And the frequency is not 6 times a day, because that's what I prescribe for mechanical testing and mechanical treatments. But for tissue, 2 to 3 times a day is what I find to be okay. Some people might do more or less. On our 8th visit, he's like, yeah, it's a bit looser. It's a little bit less painful. He doesn't really notice daily pain anymore with his daily activities. External rotation was now about 95 degrees, so still, 30 degrees different than his other arm. And he noticed that at the end range of all these movements now, that he'd been stretching it for about 3 weeks. So I let him do it for 3 weeks. He'd been stretching for about 3 weeks, and now when he got to end range with those restricted motions, it wasn't painful, it was just uncomfortable. So when I could feel the end range, because of course I'm applying overpressure to each plane of motion to feel it and to get it to end range so I can, assess how far it goes, it no longer felt as kind of restricted when I pushed on it. Part of mobility testing is me feeling the restriction at the end of the range or the obstruction at the end of the range. Does it feel like it's getting looser, basically? And I wrote down that I was getting looser. External rotation was a little bit more springy when we tested it in supine. So we reviewed what he was doing for his home program. My clinical judgment was continue with this. You can wean off the neck if you find that you're doing fine with it. We reviewed, via a handout, what are the 8 planes of motion of the neck? How do you keep it healthy, maintain motion in all these planes? Doing your neck exercise either seated or prone, whichever one was able to keep you with a healthy neck that moves well in all directions. Do that one. Maybe it's once a day, maybe it's once a week, maybe it's after you work out. Whatever works for that individual patient is what I'm there for. And then I said continue with that, 2 to 3 times a day, stretching the shoulder in those 4 planes of motion that are limited. And if not fully resolved in 4 to 8 weeks, that was my best guess, let me know and we'd meet up again. But I kind of anticipated it this time. I told him, look, mechanical problems are fixed quickly, but restricted tissue problems take longer. So while we saw rapid changes with neck movements in terms of shoulder mobility and pain, we weren't seeing rapid changes with the remaining pain and shoulder mobility with shoulder movements. Those would take longer. That's why I spaced out between our 7th and 8th visit being 3 weeks, and that's why at the 8th visit I was like, look, if in 2 months you're not convinced this is moving better, let me know. We emailed several months after that, and he said he was doing great. So again, this is a case where it's fun to figure these things out, right? You have lots of differential diagnoses in your head when the person's talking to you, notably neck mechanical joint derangement or thoracic, shoulder joint derangement, frozen shoulder, tendonitis, other. And I kind of talked through how I thought about those things and where I went. But in my mind and in his mind, this was a kind of good plan of care and good outcome. 8 visits over, I said, about 10 weeks. And you can observe that I'm not talking about a lot of manual therapy, right? I didn't stretch him, I didn't massage him, I didn't do any modalities other than a little bit of overpressure at end range for some of his joint movements. But it's a plan of care or an episode of care that was really centered on having the patient move his own body. And for me as a clinician, my job is to figure out if movement is appropriate, and if so, which movement. And I find most patients need just 1 or 2 movements to fix their disorder. He would not be that. He needed 2 movements of his neck to really get the problem fixed, retraction, extension, and left side bend. But for his shoulder, because it wasn't mechanical at that point, he needed 4 movements on a regular basis. So most patients I find are mechanical and we can use 1 or 2 movements performed repeatedly. But this case demonstrates that if it's not mechanical, then we have to, assess what's going on. For me, I just thought his shoulder was a teeny bit frozen there with minimal loss in 4 motions, and therefore he needed to stretch those to get it back to full pain-free neck motion and shoulder mobility and function. Those were our goals from the outset, and those were achieved with our episode of care.